Studies have shown the effectiveness of programs that incorporate community health workers. So these are trained, non-professional people who really help promote healthy behaviors amongst their peers and to act as liaisons with medical services. The AZHCF Healthcare Foundation has awarded numerous grants to programs that have done a really great job incorporating these community-based advocates, including health coaches, promoters, and ambassadors into their programs. During this morning's session, we're going to hear from 4 grant awardees who are using peer coaches in various ways to help improve cardiovascular health. To begin, I'd like to introduce our panel. You guys all know Dr. Jim Blissetto, and our first speaker next to him is Jessica Eglinton, who is the Executive Assistant at Catherine's Health Center in Grand Rapids, Michigan. She's here this morning to discuss their Healthy Heart Team Whole Hearts program. Welcome. Catherine's Health Center has received 6 years of funding from the foundation. Next on the panel is Elsa Haig, who is a Policy and Research Associate at City HealthWorks in New York. She's here to discuss the extending care for hypertension, congestive heart failure, and diabetes beyond the confines of the healthcare system via neighborhood-based coaching integrated with primary care programs. City HealthWorks has received 3 years of funding from the foundation. And next we'll hear from Yvette DeLuca, who is the Director Health Equity at El Sol Neighborhood Educational Center in San Bernardino, California. She's here to talk about the My Heart, My Health program. She's also joined by Alexander Fajardo, who is the Executive Director who will serve on a panelist with her today. And finally, we have our last grants awardee on the panel, Tiffany Grant, who is the Program Director. She's here to talk about the Take Control of Your Health program at Mallory Community Health Center in Lexington, Mississippi. Mallory Community Health Center has received 5 years of funding from the foundation. So our first speaker is Catherine's Health Center, who is one of our many grant awardees who are using health coaches to really help improve cardiovascular health. If I may please welcome Jessica up.
All right. Can you hear me okay? Wonderful. Hi, everyone. My name is Jess Eglinton, and I'm from Catherine's Health Center. I'm here to talk to you a bit about our Heart Smart Connections and Whole Hearts program. So, at Catherine's Health Center, we're located in Grand Rapids, Michigan. If you've ever met someone from Michigan, they've probably explained to you where they're located by showing you their hand. We're from the Mitten State, and so Grand Rapids is located approximately here. My apologies for those who are joining us remotely and can't see my hand. But in Michigan, heart disease is our leading cause of death. We rank number 8 nationwide in terms of cardiovascular burden. Within our more immediate community of Kent County, we see that 4.8% of residents have been diagnosed with heart disease. This is over 476,000 individuals. Not only that, but we see high rates of other conditions that are associated with heart disease, including high blood pressure. 23.5% of residents have been told by a doctor that they have high blood pressure. We also see high rates of obesity, high cholesterol, and diabetes. So heart health is a big concern within our community. As a community health center who serves the underserved, we knew that we needed to engage our patients really as active partners in their care in order to improve their heart health. And we do that by employing a number of different program approaches, including cross-sector partnerships, one-on-one health education by using our health coaches, affordable health insurance navigation, care management, and integrated behavioral health services. Now, I want to focus my talk today on how we use our health coaches, because this has been foundational for our program over the past 6 years that we've been funded. So we use our health coaches who are typically volunteers who provide one-on-one risk reduction counseling, goal setting, and follow-up. Now, with health coaching as the foundation of our program, we've seen some dramatic impact. And we have a lot of data, so I pulled out some of our most recent data. We had a group of patients, 761 patients, who had participated in our program for at least a year. And after that time, we saw the following outcomes. 41.5% of our participants had decreased their BMI by an average of 2.2. At the end of at least 1 year, 74.5% of our participants had a blood pressure that was lower than 140/90. 57% decreased their total cholesterol by an average of 31.9, and 58.2% decreased their glucose by an average of 27.6. In addition to that, this group of patients, after at least 1 year's time, we saw that they decreased their ER visits by 390 visits within that year. Now, this is dramatic. This is the kind of impact that we want to see for a long time to come. And the way that you make sure that happens is by focusing on sustainability. So we have 2 approaches to ensuring sustainability in our program. And those are, first, to make sure that we're integrating each new piece of our program really carefully into the workflow of how we function as a clinic. And second, we want to make sure that we have robust volunteer interest, that we have a constant stream of volunteers coming to us who are eager to serve as health coaches, so that we can spend our energy mentoring and training them as opposed to continually spending our time in recruitment. Now, we've had many opportunities to share our success, and I want to highlight some of those that we've had within state and nationwide organizations. We've had the great honor of presenting at the National Association of Free and Charitable Clinics, as well as the Great Lakes chapter of the Society of Public Health Education. And this coming week, we'll be flying to Orlando, Florida, to present at the Institute of Healthcare Improvement. So we're thrilled about that. Now, with any program, you're going to come across some challenges. That's part of the process. And I suspect that you will be able to resonate with some of the challenges I'm going to talk about today. We simply did not have enough staff to do the work that needed to be done to improve heart health on a large scale throughout our patients. So we strategically identified community partners that we could build partnerships with to recruit volunteers in a steady stream. Now, when you're working with a group of people, a large group of people, and you're implementing a new program, it can be difficult to ensure consistent communication and services being offered to your patient population. This is especially true if you're working with 10 to 15 volunteers who maybe spend 2 or 3 hours in your clinic per week at the most. So we quickly learned that we needed to build a structure of a volunteer leadership within our group of volunteers. So we made sure that we had our AmeriCorps and VISTA members who were serving 30 to 40 hours a week within our clinic. They became the champions of this portion of our program. They became the experts, the ones who could mentor and train those volunteers who are coming in, supervise them, make sure they were providing consistency of services, and that they felt really comfortable in providing those services to patients. As I mentioned, I'm just touching on a few of our challenges, but I'd like to highlight some of our most useful tools when we address challenges. One in particular is a technique called motivational interviewing. This is a technique that our health coaches use to really identify and elicit the patient's motivation for living a healthier lifestyle. We all know that making lifestyle changes can be very difficult. So when you focus on that patient's internal motivation for being healthy, whether that's being around to support a family member or taking care of a family member, that can be crucial to keeping them on track. We also built community partnerships, specifically with colleges and universities that had health-centered programs. We knew that there were lots of book-smart young people in our community who were eager to work one-on-one with patients and to get that experience before they went on to medical school or to nurse practitioner school. So we have a steady stream of volunteers from those student groups and university programs who come to us on a regular basis, and we can depend on them. If ever we encountered a challenge that we were not well equipped to address, we would look to our broader community to address that issue. And we also learned that it's incredibly important when you're working with volunteers, or even if you have staff transitions, to make sure that you have a well-documented workflow inventory for how you do things. If your volunteer leaders are transitioning after a year, having that workflow inventory is going to keep your volunteers from going through that long learning curve. We've learned many lessons throughout this process, but I want to highlight 3 of them. The first is you need to involve your patients in every step of the development of your program. You're going to see higher rates of engagement and just ownership over the program when you involve patients in every step of the way. Not only that, but don't reinvent the wheel. This is something that in a few different ways we learned the hard way. There are so many programs around the country like ours, like the YMCA or Manna Ministries, that are doing great work within the community. We need to be aware of those programs throughout the country, see what could work well within our community, and then leverage those and bring them on site to meet the needs of our patients. Another thing, start small, focus on one piece at a time. I've mentioned that our program has 5 different approaches. Each are robust in their own element. But we started 6 years ago with focusing on health coaches and building those as our foundation for the program. Once we became experts in that process and providing that support to our patients, then we could look to other needs that needed to be addressed, including care management or integrating behavioral health services. We would not have been nearly as successful if we spread ourselves really thin and tried to implement all of those complex programs at the same time. Now, as I said, challenges are always expected. This is just part of the process. One of the challenges that we're experiencing now is working with volunteers that you're very dependent on their availability. A couple of the programs within our community have recently transitioned their curriculum, so the students are no longer available at the same time of year or for the same duration that we had come to count on. So we're trying to figure that out in terms of providing consistent quantity and quality of health education for our patients. And we are delving into creative solutions to this problem and other challenges, and we're honored to be here to creatively problem solve with the rest of you. Thank you.
Thank you so much, Jess. Our next presenter uses home-based health coaching models to help improve heart health in New York. I'd like to welcome Elsa Haig to the podium to present on the Extending Care for Hypertension, Congestive Heart Failure, and Diabetes program.
So I won't repeat the long title of our program, but very excited to share what we're working on. So we're based in Harlem, New York. City HealthWorks was launched in 2012, and we started out just in East Harlem, New York, but we now serve all of Upper Manhattan. So I won't repeat the national statistics. We all know that the cardiovascular health need is incredibly urgent. 50% of US healthcare expenditures are on just 5% of the population, and I think most of the clients that we all serve are within that 5%. Within East Harlem, New York, where we started out, the statistics are much worse than the rest of New York City as a whole. 38% of Harlem residents live below the poverty line. Heart disease hospitalizations occur 45% more in East Harlem than they do in New York City as a whole. So a lot of different reasons for this, but the clients that we serve fall within that. And mostly are eligible for Medicare and Medicaid. Our average age is 63, and most clients have at least 7 different medications that they take and multiple chronic illnesses. So complex patients with a lot of needs and a lot of social barriers as well. The goal of our program is to scale up this health coaching program and to demonstrate that it can be replicated across the country and that it can be paid for by insurers and hospitals, and that this workforce is a workforce to be valued and, when possible, paid with the help of insurance companies and hospitals who will gain great benefit. While doing that and while saving money for these health systems, also improving health outcomes, which is the most important part, hypertension control and health disparities. The approach for our program, we also use a motivational interviewing based approach and do motivational health coaching and ongoing care coordination. We hire our health coaches from the neighborhood that they're serving, a minimum of a GED, and we provide them with a health supervisor who is a RD and diabetes educator. So they have ongoing supervision and ongoing training. It's not just a one-time thing, it's ongoing throughout their time with City HealthWorks. They're all salaried with benefits. So the health coaches also, in addition to doing that education on nutrition and goal setting and navigating social services and clinic services, teaching about healthy coping, the health coaches also escalate urgent and emerging issues, medical, psychosocial, and by bringing those issues to the attention of the clinic, they're able to prevent ER visits and resolve medication adherence issues much more quickly and bring great benefit to the clinic and to the client. So we serve as this bridge and partner to the clinics and patients, and so we're able to extend the reach of that clinic into the community where people live, work, play, and do all of those important activities for living a healthy life. So our impact to date, before I get into some of our hard data, I'm going to tell you about one of our clients, Miss Y, 69 years old. She was the first referral for our congestive heart failure program, which we launched in August. So this program is slightly different from our other services in that we take the referrals from an inpatient setting. For our other programs, the clinicians refer patients who are seeing them in an outpatient setting. So with this client, she is a cancer survivor, she has diabetes, she has multiple chronic illnesses, as well as congestive heart failure. And since January 2017, she had had 9 different ER visits and admissions for congestive heart failure. So despite all of this time with her healthcare providers, the education just wasn't working and something wasn't connecting there because she kept having to go back to the ER. Very quickly, she was paired up with a health coach, Hilda. She met her for the first time at the bedside, even before she was discharged from the hospital. And she was able to learn better self-management skills, how to take her meds correctly, how to properly monitor her weight, and restricting fluids and salt. She had a misconception that she only needed to be tracking her water intake, not all of her fluid intake. So the health coach was able to help her understand she needed to track soda, she needed to track any fluid she was having. That immediately had a big impact on being able to monitor her symptoms. And Hilda and the client were able to recognize 2 instances of worsening symptoms, and the health coach was able to speak directly to the heart team at the hospital, and they were able to manage that without the client having to go to the ER. So in the first 30 days, the client didn't return to the ER. That's a big win for the hospital because they don't get dinged with that readmission penalty. So we've already saved them a ton of money, and our client is feeling much better and is able to understand what's going on with her body. So in addition, in our diabetes program, 83% of participants reduced their A1C, with an average reduction of 1.11 points. And our nutrition knowledge scores increased by about 18%, our CVD scores by 40%, and number of days of exercise increased by 20%. We also measure our Net Promoter Score, which is a measure of client satisfaction with the service. And the score goes from -100 to 100. Our score is 92. We're very proud of that. Our clients really form a really close bond with their health coach. In some cases, our health coaches are living in the same building as their clients, so they really have a tight connection with them. We also see a reduction in depression scores over the course of the program. Our health coaches are not mental health professionals, but just having this relationship with someone who takes the time to do education in a way that is able to work for that person and takes the time to listen to what barriers they're facing, that alone has an impact. And then our health coaches also make a lot of referrals out to other services to manage different barriers. So sustainability and dissemination, as I said, that's one of the central goals of our program, is to get it paid for and make sure that this kind of model is valued in our healthcare system and can address all of these things that we know have so much impact on long-term outcomes. So in 2016, 10% of our revenue came from earned revenue, and this year we're at 33%. We're very proud of that. We spend a lot of time on developing more contracts and also on doing multiple evaluations of our impact. So we have 3 different evaluations with matched controls going on right now. We'll have data for all of that in 2018. One is for looking at our impact on diabetes and hypertension, one at congestive heart failure, and one unrelated to AZHCF on asthma. So for the diabetes and hypertension one in particular, we're excited. We're going to have access to Medicaid claims data. So in addition to seeing the clinical outcomes, we'll be able to see the impact on cost. We also have been working with the Urban Institute, a think tank based out of Washington, D.C., to develop a policy brief about medication adherence and what impact our health coaches have on changing a client's ability to take their medications properly and how that impacts outcomes. We're also doing a qualitative study to look at what components of health coaching are the key ingredients, the secret sauce for success. We've gotten some great press coverage. We had a Politico article, which I think is in the back of the binders, which we're really happy with how they told the story of our work. And we'll have a video coming from Great Big Story, which is a part of TED and CNN. So that will come out at some point in 2018. We've done various presentations. We did one with our clinician champions at one of our clinic sites. That's also in the back of the binder, at the Society for General Internal Medicine. I participated in the Global Health Delivery Online Forum earlier in the summer, and that was a forum for people from all over the world. And we talked, my topic was focused on our workforce components and how we do recruitment and training. And there will be a policy brief coming out from that through the Harvard Business Press, and that will talk about best practices. Challenges overcome. It's been a little bit, because we aren't providing direct care, accessing clinical data can be very challenging and time consuming. So we had a lot of issues with that. One thing that we've done to help address it, we incorporate the requirements for the clinics for sending us data when we come up with our business associate agreement with them and while we're doing our clinic integration process. So that's helped with getting the data. It still doesn't resolve the issues of if a clinic doesn't collect the data. It doesn't matter how much we get, it just might not be there. And then complex psychosocial and economic needs, it just takes longer to move through the program. So we offer more flexibility. Finally, lessons learned. Needs to be really flexible. As we work with different sites, patients have different levels of complexity. We've all talked about this a lot. Collaborating early and often. We started out working with clinics a lot, but we didn't work as much with the insurance companies. And we're finding now, as we're moving into contracting, that it would have been great if we had started that a little bit earlier. Current challenges, getting enough referrals. We get referrals from the clinics. We've started also going to more community events, and that's been very fruitful. Clinical referrals, we're trying some more stuff with that. We've established an electronic referral system, and that's helped, but we're still plugging away at those challenges. Yeah. Thank you very much.
Thank you so much, Elsa. Despite ending with challenges, you can tell how successful your program already is. Our next presenter is from Ellisville Neighborhood Education Center, who is using promoter-led programs to help improve cardiovascular health for Latinos and African Americans in San Bernardino, California. Please welcome Yvette DeLuca.
Thank you. Good morning, everyone, and thank you so much. And just one quick point of clarification. I'm actually the Director of Health Equity with Partners for Better Health, and we're a very strategic, long-standing partner with El Sol. The complexities of healthcare navigation and chronic disease in our region entail really strategic, trusting partnerships such as ours. So we've worked together for some time. How many of you have been to San Bernardino, California? Anyone? Okay, great. So I've provided some, or we've provided some high-level data points about the county, but I want to talk between the data points too. So heart disease, like you've heard from all of the other organizations and regional localities, is the #1 cause of mortality in our county. We didn't know quite how to approach it because if you've been to our county, we're larger than many states. So one of our borders extends all the way to Nevada. And then our west end border ends just about where Claremont is. So it's been really tricky to get a foothold across our county and address the chronic disease burdens and, most importantly, the social determinants of health. So like I said, I provided these data points. You can read them in your packet. What I'd really like to call out is or are the health disparities that African Americans and Latino populations experience. So a man who is of color and lives in San Bernardino County will live 10 years less than a man who is of color and lives in Northern California. Our region is also known as the third California. The Brookings Institute labeled us as such because our region is considered to be developing. Now, we have strong assets such as the partnerships that I mentioned, but it is ethically, morally, and from a healthcare standpoint, deplorable that people of color live, less than people of color in the northern part of our state or even Los Angeles. 19% of adults could not see a primary care provider in the past 12 months. This is a 2015 statistic. I'll talk a little more about our pilot area focus and the local data that we were able to collect through a web-based public-facing data platform that we actually built to support our project. Just about 25% of Medicare patients were treated for heart disease. And the next bullet point, 23% of our program participants cannot afford regular medical care. So now I'd like to get a little more granular and talk about the City of Ontario. We decided to focus our pilot project, Mi Corazón, Mi Salud, My Heart, My Life, in the City of Ontario for several reasons. One, if any of you use UCLA's Cal and ViroScreen 3.0 data for social determinants of health, the City of Ontario has the worst air quality in California. And one of the reasons is because it's the heart of the goods movement service. And we have 5 highways there. So we have folks, people of color, who are having high asthma, high obesity, high heart disease rates, and it's because of the environment where they live. So we decided to focus on the City of Ontario. The City of Ontario also has a 67% overweight obesity rate. And of course, people of color are really make up the majority of that statistic. So our program goal is to improve cardiovascular health and also address the obesity epidemic. We have an epidemic in our city. Among Latinos and African Americans by implementing a promotores or community health worker and community-driven project designed to change knowledge, attitudes, skills, and behaviors associated with cardiovascular health. And we do this through, we think, a pretty innovative model that takes Mi Corazón, Mi Salud as the heart of this model, but it's a systems approach model that involves shared data. It involves building health hubs or community-facing health hubs and health homes. If any of you follow the Prevention Institute, there have been white papers written about the effectiveness of community-facing medical homes in underserved areas, and that's what we've really built through a community lens. And we partner strategically with our hospital partner who has made incredible investments in this program, and I'll talk about that. But we focused on a hotspot area for our hospital. It's where they had the medical bleed and the financial bleed in the City of Ontario, so I'll talk about that. Our program approach is pretty complex, but the nitty-gritty is that El Sol takes the lead in designing and delivering a culturally relevant curriculum and promotora model. Secondly, I'd already talked yesterday about the Zoom Up economic mobility Zumba classes. That we did that first. We laid the groundwork by creating free exercise sessions. People can roll out of bed, and there are 40 free classes across the city that connects with the hospital, but it's in the area where these folks live. There's a flexible maintenance program. It's modified for any individual. And there's individualization through a toolbox of adherence strategies that our hospital partner trained us on. So lastly, there's care coordination. I'll talk more about that. So I better advance because I'm midway. Let me talk about Elvira. I didn't mean to snap. But so Elvira lives in the area that I described in a 1.5-mile radius in Ontario. She is an immigrant. She's a grandma. She's a mother. She's raising 2 sons on her own. And because of that goods movement service that I talked about, she worked in a factory and she got laid off. She has fallen through the cracks of the healthcare system, but was going to the emergency department at our hospital partner, San Antonio Regional Hospital. Doesn't have insurance. And she, right here, is holding a card from Know Your Numbers, which is a screening, a biometric screening intervention that the hospital tried to implement in the community, but had no recruitment and retention. And through the use of El Sol's promotores, we were able to implement this, Know Your Numbers, biometric screening intervention across the health hubs that I described. Our recruitment has been so powerful that we have a waiting list. Currently, there are about 75 residents on the waiting list for this screening program where promotoras take the lead. Elvira had breast cancer, and she didn't have a PCP. She didn't have a care home. She needed to lose 15 pounds in order to be treated for her breast cancer and receive the reconstructive surgery that she desperately needed. And after one of our Zumba classes, she connected with one of our promotoras who told her about the Know Your Numbers screening, told her about the lifestyle modification, helped her get insured, and connected her with one of our hospital partners. Across the board, we've seen our norm when we prepared this PowerPoint was 262 participants. We're still closing out the last quarter of our one-year grant. So our participants are well above 300 now, and we actually have higher outcomes to report. But this was our point in time. Across the 262 participants, we've had a 21% improvement in BMI. We're seeing across these biometric indicators improvements across the board. So you can read the improvements here, 17% improvement in total cholesterol, almost 30% improvement in HDL, almost 21% in triglycerides, almost 16% in low density lipoprotein. Right here we've had an average weight loss of 9 pounds. Rosario, who you can see, she's one of our promotoras up there, she has lost 67 pounds. She no longer has to take her high blood pressure, and she has become both a promotora and a Zumba instructor, and she's been really critical to the success. She's actually the promotora who brought Elvira into the program. Most importantly, none of these participants even knew what BMI was before entering Mi Corazón, Mi Salud, or Know Your Numbers. What I want to talk about as far as sustainability and dissemination. So our intervention has been so impactful that our hospital partner, again, please recall they tried to do a Know Your Numbers biometric screening intervention outside their clinical walls, and they could get no one to come in. So the hospital invested in the clinical community health workers as part of their workforce development strategy, and they're integrating the health workers into their system. Sustainability, we received bridge funding 1 year that will span 2018 in order for this team to be integrated into the hospital's workforce by our Department of Public Health. Also, okay, I can go to the next slide. Sorry, I'm just trying to be respectful of time. Thank you. Let me talk about challenges. So I think a lot was said yesterday about the politicization that's been going on about immigration. And it really impacted our program in January. The clinical community health workers came to me and said, please, we can't even talk about health. We can't talk about weight loss because people are so angry and fearful. So what we did, our hospital partners, El Sol and PBH, we said, don't. Talk about safety. And that allowed us, about 30 days, we listened to the community, and I'll wrap up with this. We listened to the community, and come February, we were able to, because we were active listeners, go back into talking about health, and our program has been very successful as a result. I already talked about the caseload distribution. We have a huge wait list, and there aren't enough clinical community health workers to do the case management and provide the health coaching that the population demands. Transitioning from a paper-based to a paperless system, we have that web-based public-facing platform that we're integrating with the hospital's EHR system and the clinic's EHR system, and we need to invest resources to train our clinical community health workers to really make that leap. Okay, effective practices. I'll just talk about blending and braiding. The hospital used their community benefit dollars to invest in this clinical community health worker team, along with AstraZeneca, which provided the backbone funding, so thank you so much for that, and deploys their clinical team, including a physician, an RN, and phlebotomists, into the community using their community benefit dollars. I would recommend everyone approach your hospital. First, do the analysis and see how much they're spending on community benefits. Go in with that knowledge and then see if they'll make that investment. So all of us, I'll end with the blending and braiding. We've all put skin in the game. Also put the AstraZeneca Healthcare Foundation dollars in. PBH put some other dollars in. The city and the hospital all put their dollars in, and that will ensure that this is sustainable. I'm sorry I went over time. Thank you very much.
Thank you so much, Yvette. I really loved hearing really the impact that you're making on specific patients like Avita. And my apologies, I think I have been mispronouncing promotores, and it sounds so beautiful coming from you. Our last presenter is using a health coaching model in Lexington, Mississippi, and here to present on the Take Control of Your Health program is Tiffany Grant. Thank you.
Good morning. I have the pleasure to talk to you about a program that's one of the highlights of my life and what I do, which is the Take Control of Your Health program, which is located. We serve 3 counties. We're located in central Mississippi and northern Mississippi, and we serve the counties of LaFleur, Holmes, and Madison. So in 2015, Mississippi was ranked #1 for cardiovascular disease death rates. And if you notice, one of the counties that we serve, which is LaFleur County, is ranked among the top 20 in the United States. As well as in Holmes County, they have the lowest expectancy rate as far as their life, access to food, access as far as transportation. And if you already don't know, Mississippi is have high obesity rates, overweight. We're 71.3%. And we're also ranked #1 as it relates to diabetes. So our program goal is to improve metabolic control, psychosocial outcomes, and quality of life to reduce diabetes-related complications, such as cardiovascular disease, among Mallory Community Health Centers network. We have a 3-month to 4-month program, and our participants have the opportunity to receive free complimentary physical, nutritional, and psychosocial assessments. And that's provided by our nurses, our behavioral health specialists, and registered dietitians, along with our providers. Our participants meet weekly, and we have group activities, and the classes are basically based upon them and their needs and what they need to talk about. I may come in with an idea, but it really revolves around them because it's their program, and we really want them to have that value of it. So, but typically we really focus on healthy eating, the importance of physical activity, daily monitoring of blood glucose. We really encourage taking control of your health and asking questions and feeling confident in asking questions when you meet with your provider. We talk about medication management, and we provide healthy coping skills. Thank you. So the results that I currently have up are from this year's program. This is the second year we focused on diabetes-related complications and kind of had a gear to that and trying to reduce those cardiovascular risks. So this spring/winter program, we had 94 participants. And the results of this program, this year's program, is as follows. 76% of participants increased their HDL by 2 or more points. 58 of those participants reduced both their systolic and their diastolic blood pressure during the period by 2 or more points, and then increasing physical activity. So 69% of those participants reported increase in physical activity of 30 minutes per day, at least 5 days per week. As well as we also talk about nutrition. And so throughout this whole process, 83% of participants scored greater than 80% or higher on their nutrition knowledge survey, as well as increasing their knowledge of cardiovascular disease. A huge way that we work to sustain our program is leveraging partnerships and working with our resources within our community. And one of those partnerships include working with the Department of Health as they have the Community Health Worker Program, which was a really great program because it helps support all the things that we're doing. So we utilize these community health workers to communicate with our participants, to follow up with those participants, to talk to them again about medication management, to encourage them to follow up with their visits with their provider. Also measuring their blood pressure, being an advocate for their health and taking control of that health. Another opportunity that we have is we have the Life Smart Obesity Program, which is the program that really focuses on chronic conditions. So these patients can come to this monthly class to talk about the various chronic conditions, how do you manage this, stress management, because that's another huge component of the clients that we work with. We have currently developed a Take Control of Your Health fact sheet that our providers as well as other community workers can go out to promote our program. It has information as it relates to our results as well as what the activities and the fun activities that we're doing. And, you know, it's used as recruitment, but also as an opportunity to tell our story. So just like we heard yesterday, there are lots of challenges. And one of those challenges is waning motivation. At the beginning, everyone's so excited about the program, and they come every day, and they bring friends along. And but then somewhere in the middle, that excitement kind of fades off. And what we've been kind of doing is, again, buddy system, meet a new friend. We try to really do things for people to have that opportunity to interact with one another. As I said, during the class, I may have an idea of what we're going to talk about, but I really let them drive that. And I really may, if that person is missing, then, well, where's your buddy today? And they'll tell me, like, oh, she's doing X, Y, and Z. So they really keep up with one another. They don't see one another at the gym. They're constantly calling. They look forward to 5:30 water aerobics, and they know who comes and who's supposed to be there. And then on Thursday night, another group goes at 6:30. So they really have built this network amongst themselves. As you all mentioned yesterday, transportation is also a concern and an issue. So with this buddy network, we found out who lives in the same community with you so that they can have the opportunity to carpool with one another. Again, that's your buddy when you come to class, but they've built a friendship and a relationship. And sometimes they're still there when I'm leaving, still talking with one another and interacting with one another. And they're like, bye, Miss Tiffany. But I'm like, are you guys going home anytime soon? It's getting like, you know, dark out here. It's like 8 o'clock. But they're enjoying that camaraderie so much. Another thing is that family issues. You have people that are working, but they're the working poor. So they have 2 and 3 jobs just to sustain their lifestyle. And because this is a new lifestyle, sometimes you don't always have that support because you may be eating healthier, you may be losing weight, and sometimes that partner may not feel as confident and they feel as though they're going to lose that person because of those changes that they're making. So we really try to promote the family, either bringing your support person with you, just really encouraging them and saying that this is for all of us. I'm trying to take care of the whole family versus I'm just losing this, you know, you may leave me, because that's a really concern, that that person may leave them because they've lost this weight or they're making these changes. And another opportunity is that we do provide them as an incentive some in-home exercise and DVDs as well. So if there is a transportation issue as far as going to the fitness center, that's an opportunity for them to be physically active also. This slide here just talks about one of the days that we did a grocery store tour. And so I was going through some of the things that they can purchase and having, you know, they did buy the greens and things that you can add to it to make it healthier. Because again, we're asking these people to change their lifestyles, but we want it to be something that will be fit for their lifestyle and something that they're able to do. Lessons learned. Again, I'm dealing with a group of people who have been cooking this way all their life. So I have to do some creative, healthy recipes and swaps for them, as well as and letting them try it and exposing them to new foods and new things that they probably would never try if I wouldn't have exposed it to them. So I was telling someone the other day, we had spaghetti squash, and at first they were a little kind of not interested in trying it. But once the first person took a first bite, it was like, oh, let's all try it. They got them so much more excited about it. But we needed that champion that's kind of like the leader of the group to be the one to try it first. And once she did it, everyone was on board. They were like, how do you cook this? Bring recipes. So I came the next week with all the different recipes. Other effective practices, promoting motivation each week. That's really important. So they look forward to the incentives, and the incentives are based upon the current lesson and or that verbal communication. They look forward to that. You did it, great job type of attitude. Just like everyone else, we still are concerned with attrition. We're also concerned with just participants focusing on their self and understanding that they have value and that self-esteem. And so that's really where our behavioral health specialists and making and having those partnerships and making those friends really kind of helps, because really they have to realize that they're important too. And I always have to tell them that you can't be the best you unless you take care of you first. Thank you.
Thank you so much. At this time, I'd like to ask all of you to turn on your microphones. I thought it's interesting because I know some of your programs have models where you have volunteer health coaches, and some I've heard have paid health coaches. I'm curious what your thoughts are. Is there an advantage or disadvantage to each model, and what do you think is more effective?
Our agency, we have been implementing promotores for almost 20 years. So we have an agency of promotores or community health workers. So through the process of these past years, we have been seeing the difference. So we create different, like an umbrella for each of the interventions they are going to be working on, but also how they are going to be hired or how they are going to be implemented. So we divide volunteers. We have fee for service. So in case they want to do something, so they get fee for service, we have part-times and full-times. In my experience, the most effective ones are those ones that are getting paid because they have more commitment, not because they have the time to be there. The volunteers, they have other commitments as well. So sometimes they just commit a few hours, maybe if they cannot make it to the class, so they don't show up because they are volunteers. So I think fee for service or pay has been in terms of retention of the staff of the promoters are more effective. Now we are doing is volunteers, and they start growing, they start learning, and they move to we have a grant, they move to a fee for service, and then after they get part-time and then a full-time. That's our experience.
When we first started, our organization wasn't in a position where it was feasible to hire full-time staff to do this work. So we built it up over time. First, we started with very, very part-time volunteers. then working towards using AmeriCorps and VISTA members who could serve basically as full-time, but they're volunteers getting paid by the government. And now we've been able to build sustainability into our program so that we have 2 key staff members that focus on being the lead health coaches, and then they mentor our team of 10 to 15 volunteers.
Could I add one thing as well? I think it depends on where in a system the community health workers are working, because ours work in community-based settings. Quality assurance is really critical, and we wanted to align quality assurance and quality control with our hospital and clinics QA/QC processes, and we found that paid community health workers were more impactful in that.
We found with the workforce development component of our program is just as important as the health outcomes, and that by having these full-time positions with benefits, with salaries, and ongoing supervision, performance reviews, bring more stability into the community that we're serving. So coming at it from a lot of different angles. And as well with our clinic partners, it's very important to them to know that we have all those quality control things going on, and understanding that we have a rigorous performance review process, very data-driven. The health coaches are able to set their own goals for their improvement, and so we're able to see a lot of progression in their performance over time. And we have incredibly great retention for our health coaches in their positions, and that's really valuable because we're not having to retrain people all the time.
You're talking about basically training your leaders, right? Training your health coaches. And I know, Jess, you started talking about ways that you were trying to ensure consistency across how they're educating, how they're performing, and how they're communicating through the use of leaders, right? So train the trainers, if you will. What other tactics are other programs using to kind of maintain and ensure consistency across your health coaches?
Just as mentioned earlier, the train the trainer, but also we go back and we watch them, monitor them in the classroom as well. So, you know, you have to do so many trainings before you're actually considered a leader. And so also knowing that, you know, at any moment I could come in to, you know, supervise or just kind of see how it's going. So that I think helps. And we really encourage them to try to, you know, have that moment, but also remember what the focus is. Like, you definitely want to put yourself into it, but then also remember, stay with the evidence and not go to some, you know, colloquialism.
I just want to, last year we have 180 promoters in our agency across all of the, so we have a lot of experience managing. I think the training is a very key, important part. We develop an academy with the local university in order to create like a structured training to develop specific competence. And also because we're having some discussion at the state level about CHWs. But on top of that, the training, also the supervision is a very key and important aspect, but also defining the project. We have this is our REACH project. I think the skills of the promoter is different than those when they are going to be working as a case management or working with the clinic or as a health navigator. So I think doing that in screening as well of the skills that are needed, and also if the person needs to develop or already have, it will give us targeting specific approaches depending on the interventions.
Another tactic we use, the health coaches, so our coaches meet one-on-one with clients, and when they first join the organization and are getting their upfront training, after an initial classroom-based training, they go out with another health coach who's been with the organization for longer and will shadow them on visits to see them in action. And then we also have the health coaches come together about once a week, and we'll do a successes and challenges session. And so they can troubleshoot together and share, you know, I'm having this particular problem with a client. Has anyone else had that? What have you done to solve it? And that helps helps with troubleshooting and kind of just brings them together as a team. And then also our health coach supervisor will check in with each coach every week, every other week, and do case reviews to help ensure consistency and do more problem solving. And then the health coach supervisor and our director of health coaching, who have each come to this event in past years, they'll biannually as part of the performance review process. So can do control that way, and we do quality assurance phone calls to our clients as well to get feedback from them.
Yeah, that's great. You mentioned core competencies, and maybe certain people might be better in a health coach role as opposed to case management, et cetera. In your experience, what do you think those core competencies are and skills that make a really successful health coach?
So I think we develop, there is a lot of information on that. So for each intervention, so we develop kind of interventions. So we have outreach, education, health navigation, case management, chronic disease management, and clinical community health workers, which is integrating promotores in working with the clinics. Each of them have a specific competence, which I can share the information because at least you guys see how we divide it in order to define the competence for each strategy. Because the competence to do outreach is different than competence working with clinics, as an example, or case management. So we have each of the branch of the umbrella, they have a specific core competence. And then we create trainings to develop those.
For us, we found that the most important part of health coaching is the relationship between the health coach and the participant. That most people that come to us as staff members or volunteers, we can train them on how to educate folks on health education information. But you have to be able to make that connection and to really communicate empathy and understanding to someone. That's crucial to the health coaches that succeed with our program.
I just want to add something. We say we have a saying in our agencies: we hire the heart and train the brain. Mm-hmm. So that's our screening. hire the heart and train the brain.
Yeah, I think we do that in practice. It's a great way to say it. We, in our screening process, which the Global Health Delivery Forum I mentioned, when that brief comes out, there's a section that I wrote on our screening process, which one of the key components, we include our current health coaches in the screening process. We think they're the best. They're in a great position to interview candidates and see whether they see in that person the skills that they know are core. And most important is identifying people who have natural empathic listening skills, core to the motivational interviewing approach, and to listen in a non-judgmental way. Most of our health coaches also, either firsthand or for themselves or within their family, have experience with these chronic illnesses and taking care of a family member, seeing the impact in their neighborhood. And that's also really important for then developing the competency of the actual subject matter.
And I would add one competency that really will come after the foundational competencies that my colleagues described. And I think if we're looking through a workforce development lens and also a community impact lens, we need to, much like our skills today were developed with handheld devices, technology, we really need to ensure that technology is at some level a core competency for health coaches and clinical community health workers across the spectrum. And I know that that's part of the California state competency list that's being recommended. And I think we can really advance community health and workforce development if we intentionally focus on that competency too.
As looking at the themes that, again, that have developed out of all the programs across, what we've funded from a foundation standpoint, when we presented themes that we picked out at the APH meeting, I happen to be the one to talk about coaches and the use of coaches, and I can say one is using coaches is probably one of the most effective of approaches that we've seen across when we started the bucket initiatives. And there were a couple of things, and you guys have brought it out very nicely. One is it seems to be that there's that trust there, particularly if it's people within the community and people that may be known within the community, whether they're volunteers or paid, but they're known within, you know, the community and seen that way. And secondly is, and you guys brought this out very nicely, is that the consistency, like they have to be trained to a certain level, all right? Because otherwise, if you don't, then it's more of a conversation than actually what you're trying to accomplish, which is to utilize them as a tool. And the success really is around that. So making some sort of rigor around the training and making sure that they have that competence that you guys talked about, were kind of two things that really came out across the multiple programs that have used, you know, coaches as an effective tool.
Well, thank you. Several of you have mentioned the importance of using culturally relevant curriculum, right? Meaningful education that's tailored to your community. We know it's going to be different across the country. I imagine it has to be hard sometimes to find that information and those resources. So how do you go about trying to find those resources that are going to be most meaningful for your participants?
Quite honestly, we will get that feedback directly from our participants. They'll say, this doesn't make sense for my family or for my community or my budget. And it's often something that we need to train our volunteers on. With working with medical students or nurse practitioner students, these folks often come from privileged backgrounds and maybe don't understand that kale and quinoa aren't common cooking ingredients of folks who live in poverty. So being able to bridge that gap in knowledge, but our patients are very comfortable being upfront about saying, this just doesn't apply to us, and we learn the most that way.
We learn, and I will concur. They will say, like, this is not it, and they will tell you. So, you know, getting that feedback from them is so important, and my patients have no problem telling me.
Similarly, our health coaches do not hold back in telling us when, you know, oh, we found this great educational material, and show it to them. Like, no, that's not great. So they give us a lot of feedback and really guide it. And then with a really intensive quality training background, they're also able to adapt the material to that particular client. So even within, you know, one cultural group, it may not meet that client's needs depending on their level of literacy. And so they can do that adaptation on the spot because they have enough experience and enough opportunities to practice before they're out in the field that they can make it so personalized to that client.
So one of the things that we do actually through the process of these years are we develop like a basic training for promotores, which all of the promotores they need to go through that training to develop specific general competence. And depending on the intervention, we develop a specific. For example, if it's diabetes, we create like a training for diabetes, and we incorporate popular education. So we use a lot of popular education in our interventions. And then you can look at it as very important tool that relates with our community in order to implement that curriculum. Like if we have a diabetes curriculum, they need to put their own popular education component when they are implementing it in order to engage, because they know their community, they know the needs of the community. So the popular education component, it will engage and maintain the members of the community attending or participating on the intervention.
I think this is such a great question, because one lesson we learned early on in the project was that our hospital partner didn't know that heart disease in English doesn't translate in Spanish. And I would share a lesson we learned: focus groups that are around a round table where a hospital VP can sit down with the community coaches, the residents, and just have conversations, even about a flyer. that was such an aha moment for our hospital VP and CEO. And so I just wanted to add that to what Alex said. It's really cool learning when we sit down together and we just talk. We have collective intelligence.
Just have maybe an advice for whoever is gonna planning to incorporate promotores. If you already have an agency in your region that are doing promotores, and this is an expert agency, my suggestion is partner with them. We have been having some local issues when the clinic trying to implement their own promotores program or community health workers program within the clinic, and they start losing the philosophy of what is real a promotor. So the only thing they are doing there is just translate it and filling out papers. So if you have an entity who knows about promotores in your region and you want to implement I suggest to partner with them instead to you invest a lot of time to do something new within your clinic. This is something that we have been going through in our region, that they already have experience. They know how to manage, to recruit, to train, to supervise, and they developing a partnership will be easier way to like we have example with the hospital. They tried to do it and it didn't work. Now it's working.
No, thank you. I think that's interesting because we've talked over the past 2 days about the importance of community partnerships, and we've talked about, obviously, during today's session of educating our health coaches and the participants, and you touched upon the need to really sometimes educate your community partners. Have any of you else have kind of had that situation where you had an aha moment and you realized that not only do you need to educate the community, but also the partners that you have for your program?
We've had to do a lot of education with our clinician partners, and in a lot of different categories, sometimes just beginning with like, what is a community health worker? What is a health coach? And dispelling some myths about the quality of what a community health worker can be. And one of the big things we find is concern about not knowing what's going on. So, I mean, for a clinician, what's happening in the home is kind of a black box already, but then they have an additional concern that there's going to be this health coach with them and they're not going to have any idea what's going on. And so we're able to do a lot of education of, we escalate this information to you, we have protocols, the health coaches are trained, if this happens, you'll find out about it this way. And by really, mostly it comes down to just teaching them about our program so that they have confidence in the quality, so that they know that we're doing all of our quality assurance processes. That's the biggest piece, I think. And then also working with them before we launch services in that clinic to make sure that we're customizing our workflows to fit into their schedule and into their processes, because if it's too much out of that, then they're just not going to do it, and it doesn't matter how much we educate them about how their patients can benefit. If it's too many forms that they have to fill out or whatever.
Well, how do you go about really having effective coordination of care, right? If you're working with other healthcare systems, or if you're a clinic yourself within your organization, how do you ensure that it's as seamless as possible without incorporating too many processes, right, where you're creating more problems?
One of the big things for us is having our clinical supervisor for the health coaches as the main point of contact. So if a health coach finds that there's a medication issue, the health coach isn't calling the doctor, the health coach isn't emailing the clinic directly or calling the clinic coordinator. The health coach contacts their supervisor, and then the supervisor does that communication. So we really funnel things through David, and that helps streamline it and gives the doctors confidence that they're not going to be inundated with communications that are not urgent or that they don't need to be dealing with. And then we also make sure that we only bring things to the clinician if they need to see it, and if it can go to the clinic coordinator and administrator there, we do that. And so really, when we start our clinic integration process, it starts out by just understanding what roles different people play there, so that we make sure we're bringing things to the right people so we can get our clients the right care at the right time.
One of the things that we do is participating in our provider and nurse meetings on a regular basis and letting them know when we start, when we end, but also giving them updates. And so that actually helps when we are trying to get new participants. That helps with recruitment. Them knowing about it makes them want to be more involved in it and just kind of want to know about it. And what are you guys doing? Oh, let me come to a class to hear. You know, so I think that really helps in sharing our, successes with them.
At Catherine's, we're a primary care health center. So primarily we're working with providers on site with our health coaches. We've been able to fully integrate our health coaching services with all of the other medical services we provide. So our health coaches document directly into the patient's electronic chart so that other providers, other RNs or case managers can reinforce the things that the patient is discussing with the health coach, so it feels seamless for the patient.
So let me give our experience. So it's depending of the healthcare, because we are a community organization and we develop partnerships with some clinics and hospitals, and so it's depending of the level of integration in our experience. So if the community health worker is going to be really fully integrated as part of the healthcare team, that is one thing, and then maybe we have a protocol for that. But if it's just diabetes education, as an example, referral forms or referral system. So we have referral system with that specific clinic. Just put inside Maria Gonzalez needs diabetes intervention. So we do, after we receive the referral, we follow up with them, and then when we finish, we report back. This is done. This is the outcomes of intervention. I think it's depending on the level of integration with the clinic in terms of the decision, and also if it's just navigation or it is case management. So it's different levels of the roles of the community health workers can play in partnership with the clinics or within the clinics.
I'm so sorry, go ahead.
I just wanted to add one thing too. I think it depends on the system. What we saw is we were trying to create an ecosystem where the local federally qualified healthcare center would talk with the local hospital, and the clinical community health workers were a linchpin in that. And it can be difficult because the FQHC is still paperless as of this month. So that EHR connection between the hospital and the clinic was really difficult. But what we did in the interim as a proof of concept is we created a really low cost, that web-based, public-facing data platform. We built it together as partners, and we collected data through the project that was meaningful to the hospital, meaningful to the clinical community health workers, and meaningful to the FQHC. And it should be adaptive come 2018 when the clinic has their EHR system. We'll have to see, but at least it's a proof of concept.
I'm mindful of the time and that I have selfishly taken away from some of your Q&A time. So at this time, I really would like to open it up to see if any of you guys have some questions for our panel.
Great presentation, everyone. Thank you so much. Alex, you talked about the community health workers, and then you talk about the clinical community health workers. And I take it as the community health workers working with the clinic. But what are the major differences among the two groups?
I think the main difference is that the community health worker is going to be incorporated as part of the healthcare team, and they can have access of health records. Yeah, so it's more like working within the clinic as part of the healthcare team. And then they can do home visits. So they will be developing kind of a plan for each patient within the healthcare support. Okay, this is what this patient needs. Maybe showing up more visits, or maybe this person needs to have a nutrition education, so it will be more target patient based, but within the clinic. So we'll have access to all of the information as well. This is a new title is coming up with the clinical community workers.
Thank you. This was a really great and informative presentation. I had a question about the billing from the clinics. We tried to partner with the clinic and for our participants to be referred from the clinic to our program, but then the clinics stated that if they were involved with the clinic, the people would have to be enrolled, and it would be a cost connected to it with them seeing a doctor. So now we basically just refer people to the clinic if they need, further care, the clinics we partner with. How does that work with you all? Is it, because we didn't want to exclude people from being a part of the program if they would have to, be involved with a clinic for cost. Are you all directly connected, always connected with the clinic? Are participants directly recruited from the clinic to your program? And do they have to see a physician at the clinic and pay expenses? How does that work?
Ours don't. For the most part, they're connected with our clinic, but not necessarily. Oftentimes, we'll have patients who refer friends or family members. So typically what will happen is as soon as they come to our program, we'll assess them for needs. And as part of that, we'll see if they need to be established as a new patient because they don't have a primary care provider already. If that's the case, then we'll go through that process. If not, then we provide health coaching services on more of a kind of a lay level as opposed to more of an expert clinical level.
We prefer to get our referrals from clinics because then we have that integration with the primary care provider really adds to the health coaching when it can be collaborative, and we find that long term our outcomes, it's just so much easier if they're working with the provider and the health coach at the same time. And some of the clinics, so one of our partners, I talked about this as a challenge yesterday, the patients who go there, it's part of the safety net hospital, so a lot of them don't have insurance, but they're able to get care there anyway. And then some of the clinics take Medicare and Medicaid, so the patients are able to get care that way. When we get clients in from community events, it's harder for us to get access to those clinical metrics, and it can be a little bit harder to do some of the care coordination pieces that we feel are really core to getting our outcomes.
I had a question about, I'm sorry.
Yeah, just to respond to your questions. In our case, we are a community-based organization, and then we work with clinics. Sometimes with the clinics, we develop kind of agreement, and then some functions and the clinic or the hospital pay us or reimburse based on that. But just talking about the reimbursement part of the community health workers, is in our state, in California, they need to have a certification in order to the clinic and bill to the insurance. And then we were going through a process across the state, and that's why we developed this academy with Loma Linda University to have like a certification. But right now, we're changing the ACA. There were some codes there for specifically community health workers. So it's a good advance, but we don't know what's going to happen. So you can do that through if the clinic wants to have your service, they can have developed like a partnership with you, and they you provide the service, and they build. But in California, it's taking some time in order to get the certification because there is a lot of movement there of promoters. So I just went to that.
One other thing that we've done, we were able to look at cost data and see that by week 10 of the program, we were lowering the per person per month cost by $600. And that is significant savings for a clinic. And so we can come in and pitch ourselves as this is worth it. We're an investment, so that instead of us waiting for them to bill like per service interaction, our goal is to be able to be paid, at least to begin, a per member per month rate, and then with additional incentives around achieving other outcomes and stuff like that.
And if I could just add one thing, because I think this is the heart of the matter, is billability. One of the things that I had bulleted in our presentation was we can learn together. I'd like to learn across states. We're working with the Inland Empire Health Plan, which is our region's largest insurance company, especially for Medi-Medi populations. And through their Bridging for Health initiative, they are trying to prove that clinical community health workers and community health workers can be integrated into an insurance billing system through Medicare reimbursements. So we had to scale up. We had to do a proof of concept in our pilot area and then scale up and work with larger systems to really figure out how to do this billing, how to do it effectively, and then be able to replicate. So maybe we can learn together as we learned starting in January.
I had a different question. I think it was Jessica that mentioned AmeriCorps and Vista volunteers. So I agree with Dr. Blasetto that this concept has such great power, the health coaches, and it's also been discussed the importance of cultural sensitivity. So it just made me think when you mentioned Vista and AmeriCorps folks who are almost by definition not from the community, like how does that work out? Does it somehow feel less authentic? Are they less effective if they're not, you know, sort of homegrown volunteers?
It's certainly a different feel. The interesting thing about working with AmeriCorps and Vista members in particular is that during their service period, they are paid a living stipend from the government, and that is the poverty level of the region that they're working in. So of course, they're coming from different backgrounds than the folks that they're serving with, but they're experiencing really what it looks like to live in poverty. In some cases, much more extremely than many of our patients. So we have a rigorous process of recruiting who would serve at our location as an AmeriCorps member or a Vista member, because we know that working with this population of patients, you need to really understand what it's like to live in poverty in order to address the social determinants of health. So we made sure that we were selecting great candidates who could understand that at some level. In some cases, that was people who came from these types of communities, though in other cases, that's not necessarily true.
Thank you for fascinating presentations. It's very informative. The question I have is, have any of you considered or plan on considering a small fee for members for a variety of reasons? One, when people pay for something, then they value the services more. And it also helps with retention. And over a period of time, it also provides for external validation to donors and so on. So I want to hear whether that's something which is on the books, whether it is something which you have tried out, and what your experiences have been. Thank you.
Hello? Yeah. So when I was yesterday listening about the incentives, I know there is a lot of incentives, motivation to bring people. In our case, we don't face that. I mean, we have waiting list in order to participate. So I think there is a perspective of the incentives. In my opinion, we have to create other kind of engage and attach to the program, because when the incentives leaves, what is going to happen with them? That's one thing that we have been trying to work with my team in order to how we do it. And then I know the other experts, they will be more happy to share later on how they do it. But yes, we have been thinking. I know for Zumba, for example, they pay some fee to come to Zumba because there was kind of then now is sustainability on it. So I think that's is depending on the project, depending on the community, but that's something that we have been facing. For the training, 5 years ago it was free. It was just free, everyone. Right now we are charging, especially because we partner with Loma Linda in order to have the certification. So if they want to be going through the training for the promotores, they need to pay some fee for it. Just letting you know the movement.
And just for clarity, the 40 free Zumba classes are free. But what Alex is mentioning is we've created a sustainability plan where we have bilathons. I heard someone else talk about a Zumbathon. We have bilathons so that we don't have to give the money to Zumba Corporation, but where we ask the participants to come and pay for a half-day dance-a-thon. So they're investing into this model. Additionally, our certified Zumba instructors started a wellness fund amongst them. There are 12 instructors. Every month, they contribute $5, and we've actually created, we have a pool of money that the community owns. It's currently $1,200, which may not sound like a lot, but if one of our Zumba instructors is ill or injured, then they actually can pool from that to manage their monthly living expenses.
And I apologize, we'll have to wrap that up after that answer and question.
Well, thank you so much for really, really great presentations and for all of your questions from the audience. I mean, it's very clear that these peer health coaches can really help complement healthcare providers and are doing really great work, whether it's to remove stigma or act as peer support or really provide that culturally relevant education. So thank you so much, and I really wish you all the continued luck and success with all of your programs.